I'll turn it on to Dipan, and I think is there a question-answer period or something?
Yeah,
Okay.
we got time now for Q&A.
All right. Don't be shy. Yes. This is the time.
I just had a question about looking for strain in patients with cancer who are on like Herceptin or anthracyclines. When they do have strain, what do you do at that point in terms of, do you discontinue the chemo and judge the benefit of preserving heart function with
Very important
discontinuing chemo?
Very important question. It starts a discussion. Number one, before you get the number, this technique is not error-proof. You need to know that to start with. Strain is a difficult technique. And I can almost get any number for you, bad number as opposed to a good number, if I don't get good signals from the wall. So in a poor image, just like the image is poor, strain will be poor. So don't believe any number that comes out from the laboratory. At times early on, have a check so you know whether these numbers make some sense, okay? And they have to be gotten from the vast majority of the walls. If I have 2 walls that are dropping or 3 walls that are dropping and I'm not getting a signal, this number is out, okay? So that's number one. Number two, a normal is usually more negative than 18, okay? Minus 18, why? Because this is from the apical window and the heart is shrinking, right? So it's a negative as opposed to thickening, it's a negative number. If it drops below that number or you see a trend dropping, usually it's an earlier signal than an ejection fraction. So you have a conversation with the oncologist, okay? And it could be just, depends what the options are. Usually no change in medications, maybe an addition of either a beta blocker, an ACE inhibitor, or a combination to treat that, because quite a few of them are reversible. Now, if there is a major drop in function as well as ejection fraction, this is a major conversation for a change. But it's an earlier signal that at least tells you, where are they in their chemotherapy, what are the other options, et cetera, et cetera. So I think that would be very important discussion.
As far as strain imaging goes, I've primarily seen it in patients who are getting chemotherapy that they follow it. But what are the other indications or other places we can utilize strain imaging for prognostication? And is there any outcome data where they're looking at strain imaging and outcomes based on strain imaging?
Strain for outcome appears to be, particularly in the early phase, maybe more stronger than an ejection fraction. Once you get an ejection fraction in the 30s or so, I think it's almost equivalent. The question is earlier on, because prognostically it's telling you something different. Interestingly enough, in patients with hypertension, their descent of the base and therefore strain is less. However, their radial strain increases, okay? But although their ejection fraction is normal or supernormal, they are at a worse prognosis because of LV mass and other things. So that's one area where strain could be sensitive. The other one is, just like Dr. Shah showed you, that there is infiltration with CMR and amyloidosis. It's very interesting that there's apical sparing and strain in amyloidosis. So it can tell you some different patterns, but I think it may help you also in regional function, right? Because it's not only the global strain, it's regional function if you have good signals again.
Other questions?
With regards to CTA, if you have an abnormal CTA, do you always have to go on to angiogram? Like if you do it and you see a young patient who has just a myocardial bridge, do you have to go on to angiogram before any further intervention?
Specific question about myocardial bridge. There's a recent paper following a large number of patients, I think from Europe, showing that really there's no prognostic worsening outcome. So I believe if you have a good images from the CTA showing myocardial bridge, there's no indication to go to the cath lab.
Maybe Sumin, did you touch on what are your criteria for contrast administration? Obviously with the CT contrast, one of the things concerns you have to look for is renal function And what do you guys use as criteria?
I think if the clearing clearance is more than 60, it's not a problem. Between, stage 3, if it's CKD stage 3, usually we like to have the nephrology give the blessing because it's it's an elective procedure. But between 30 and 60 clearance, we usually like to hydrate the patient before we perform the procedure. Yeah.
I mean, along these lines, think of the likelihood of disease, right? So if somebody has borderline renal function, and the likelihood of disease is more yes than no, you'd better go straight to heart catheterization and do the dye injection as opposed to going through stages of that.
I just want to add something that I didn't show in the presentation, that if you have equivocal stress test and let's say low to intermediate likelihood, one of the things you can do is non-contrast CT looking for calcium score, because the negative predictive value of a 0 calcium score is also quite powerful. We're talking about 95, 96% negative predictive value. Yeah.
There's a question over here.
I had a question about the radioisotopes. Is one better than the other, and is it just hospital protocols?
Well, definitely we don't do thallium anymore because of the dosimetry. It's a lot more radiation, and the image quality is not as good. For SPEC tracer, technetium, either tetraphosphamine or cardiolite. There's some theoretical differences, but I think from a clinical standpoint, I personally did some study comparing the diagnostic accuracy of both tracer is about the same. So whatever is cheaper.
Okay. Other questions? We have one back here.
Dr. Chen, can you please comment on the use of contrast for CT and the risk of AKI? Mainly, I've heard that the risk of AKI with the current contrast is pretty much zero, neglected. Thank you.
I'm sorry, the question is acute kidney injury. I think it's the same for any CT. There's nothing special about coronary CTA. So whatever we know about the risk of acute kidney injury, the risk is obviously current kidney dysfunction, or in the setting of acute renal failure, low ejection fraction, diabetic patient, those are higher risk. But the risk, we did a study in LVAD patient, we did, which is probably the highest risk, right? Heart failures and a lot of renal dysfunction. We done with clearance of over 45, I think that we only have 2 out of 90 cases of raised in creatinine, okay, and then which subsequently went back to the normal baseline. But again, this is obviously selective, and we didn't do that in any patient with worsening renal function. But carefully selected population with the low dose protocol, I think, if clinically is indicated, it's possible, yes.
With the increase in cardiac MRI, what's the safety of doing cardiac MRI in these patients who have defibrillators or pacemakers?
Yeah, so that's a good question. So,
Sorry. With the increase in cardiac MRI now, what is the safety of doing cardiac MRI in patients who are pacemaker dependent or who have implantable defibrillators in place?
yeah, so that's a very good question. So there's 2 answers to that. One is there's now devices that are called FDA conditional. That means that they've been approved by the FDA as an acceptable risk for doing in MRI scanning in. The FDA conditional pacemakers first came to market in 2011. Initially, it was just one vendor that offered that. Now there's at least 2 vendors in the U.S. that have FDA conditional pacemakers. For ICDs, the high-power devices, the first ones came to the market in the U.S. in 2015, and there were 2 vendors that came to market in the same year. So now the newer devices that, there's specific models that are FDA labeled for MRI scanning. The question you raised, though, is what about all these people that got devices put in before 2011 for pacemakers, before 2015 for ICDs, or even now, because all patients aren't necessarily getting the MRI-compatible devices. And so, to actually answer that question, just earlier this year, we published in the New England Journal a large multi-center registry from about 20 different sites, a total of 1,500 patients, 1,000 of which were pacemakers and 500 were defibrillators, to try to look at what is the safety of these non-approved devices. And using the protocol that we had specified in that study, we actually demonstrated no significant adverse events. And so what our current standard here is that really, as long as a device was put in after about 2000, like devices before 2000, I think there was a lot more metallic components and other issues. So most of the current devices that we're going to see in patients today, as long as the device is functional, we need to interrogate the device beforehand and reprogram the device, either to asynchronous pacing, means complete pacing, or to no pacing at all. Because the problem is, once you go inside the scanner, the sensing ability of the device goes away. Because all the electrical activity or the gradient activity that happens in the scan, the device can think that's intrinsic pacing. So as long as you pre-program it using a pre-specified protocol, we found that we can do this. And again, with this large registry, suggested that these patients can be done, but again, in a carefully monitored fashion. Yep. Okay, any other questions? Yeah, one more in the back. Anushka?
Tang, this is the question for you. So we often see stress tests being ordered for patients with high pretest probability of coronary artery disease. How often do you see negative stress tests in these patients due to balanced ischemia?
Okay, number one, balanced ischemia as defined as perfectly normal stress test in the presence of significant coronary disease is very, very rare, okay? Most of the majority of the cases when you have severe coronary disease, you're gonna have underestimation, meaning that a scan looks just slightly abnormal, but nonetheless abnormal, okay? I did a study when I was a fellow looking at about 2,000 cath and stress tests. Essentially, obviously, it's very biased because all these patients went to cardiac catheterization laboratory. Only about 2% of the patient had either three-vessel disease or left main who has completely normal scan. But most of the time, if you have very high pretest likelihood and have very lot of symptoms and you have a normal stress test, you probably don't want to stop there. This is just a test. Clinical scenario, trump any other thing.
Great. So I think we're right at 4:30. So a couple of housekeeping comments.